Thank you everybody for joining us for the Ultrasound lecture series this week. Pretty excited for this week again. So we have a repeat speaker today. We got Ziad Shaman, who's going to be speaking today from his wealth of expertise in the ICU, doing point of care ultrasound up there, talking about pulmonary hypertension and diagnosing that with point of care ultrasound. So without taking too much of his time, I'm pretty excited to turn things over to Z and look forward to what you have to say. Go ahead and take it away.
Okay, thank you, Matt. It's great to be back, and I appreciate everybody's time and joining in remotely. The goals of this lecture are three, is to understand the usefulness and limitations of point-of-care ultrasound in measuring the pulmonary artery pressure, so both usefulness and limitations, to follow an algorithmic approach to assess pulmonary hypertension, and to understand the role of other imaging modalities. I'm going to touch base on other stuff other than point-of-care ultrasound in diagnosing pulmonary hypertension. All right, so I don't have any conflicts of interest, non-financial, but I do have two disclosures, and my two disclosures are two equations. For every equation, I realize I'm going to lose half of my audience. So for the quarter of you left out there, please hang around. It's only two equations, and I'll go over them pretty in a detailed way. And they're not odd equations. One is the systolic pulmonary artery pressure equals 4 times the tricuspid regurg velocity squared plus the right atrial pressure. And this is the modified Bernoulli's equation. The other equation is actually Ohm's law, but in fluid dynamics. So you have the mean pulmonary artery pressure minus the pulmonary capillary wedge pressure, that's the pressure driving the flow, equals the cardiac output times the pulmonary vascular resistance. All right, I'll start with this case of a young lady, 38-year-old female smoker on oral contraceptives. She is presenting with dyspnea. The patient is worried because she had COVID vaccine 2 hours prior to presentation. You managed to get from the patient that the dyspnea has been progressive over a period of 6 months. She noticed it first with exertion, but now it's with rest. Actually, the patient says she can't move around her 1-story house without having severe dyspnea. And the patient has a high BMI. She is afebrile. She has a normal blood pressure. She's certainly tachypnic and hypoxic. And she has sinus tachycardia with non-specific T-wave inversions and inferior leads. And while her lower extremities are tender, your scanning partner gets some images of compressible veins in the lower extremities, and your suspicion for a DVT is low. So her BNP is high, troponin is pending, and the CBC and chemistry are normal. So you reach for the ultrasound, and you get this image, and you recognize the image as McConnell's sign. You have a pretty hyperdynamic apex. The apex is kind of bouncing in and out, but you also have a low TAPSE. And your question to yourself, is this a PE, an acute PE, or is it an RV infarct? Do you get a chest X-ray, or do you go straight to CT, suspecting you highly suspect a PE? So lucky for you, you don't have to make a decision. The chest X-ray is done. And when you're looking at the chest X-ray, you're not only looking for alternative reasons for the dyspnea other than a PE, but also because pulmonary hypertension can actually change the way the pulmonary arteries look, even on a plain film. And these pulmonary arteries are labeled here. You have the descending branch of the right pulmonary artery, and then you have the left pulmonary artery sitting separate from the aorta, making the second hump when you come down the left heart border, or left mediastinum and heart border. And you kind of remember that there is a measure that you can use to decide if somebody has evidence of pulmonary hypertension on their plain film. It's most easy to see the descending branch of the right pulmonary artery because it's separate from the from the heart border, unlike the left pulmonary artery, which is kind of silhouetted by the left heart border. So the descending branch of the pulmonary artery on the right side is separate from the right heart border. Looking at normal parameters, the upper limit of the descending branch of the right pulmonary artery is 15 millimeters in female and 17 millimeters in male. And or as I remember it from my residency, 2 centimeters is too large. That's the easiest way to remember. So you put a cursor there and you measure across to determine if the patient has high chance of having pulmonary artery pressure increase just from the plain film. And then you get the CT, of course, because you're not gonna depend only on the chest X-ray to decide. But the CT is limited. It says no central PE. There is poor opacification or motion artifact or body habitus. Something is going to degrade the image and it's not going to let you see the segmental and subsegmental arteries. And of course, there's a clinical correlation statement at the end. So it's good that there is no PE, but you can see the pulmonary artery size, and maybe you can measure the pulmonary artery on a CAT scan, like you did with the chest X-ray, to diagnose pulmonary hypertension or even to predict the actual pulmonary artery pressure from the CAT scan. So it's a good idea, and actually in 2012 there were normative data reported on the measure of the diameter of the main pulmonary artery, and also on the ratio of the pulmonary artery to the aorta. And using data from the Framingham study, looking at 706 patients with no obesity, no hypertension, no smoking history, no COPD, no PE, no diabetes or cardiovascular disease or heart valve surgery, the standards were kind of reported. And those happen to be, for the main pulmonary artery, for all screened patients, the average was 25 millimeters plus minus 3. And the 90th percentile was 28 millimeters in all comers. It was 29 in male and 27 millimeters in female. Also, the P to A ratio, which in this case is the pulmonary artery to the aorta diameter measure, was 0.8 plus minus 0.1. And the 90th percentile was 0.9. So, which tells me that as a general rule, the pulmonary artery, the main pulmonary artery, should be smaller than the aorta, just a little bit smaller than the aorta. If it's closer to the aorta size, then you have evidence of pulmonary hypertension. And if you want to measure the diameter of the pulmonary artery, the upper limit is 28 millimeters, or in this case, 3 is too big. 3 centimeters is too large. But actually, an earlier study looking at a smaller number of patients in 1984 determined if the diameter of the pulmonary artery measured by CT scan was useful for 2 things: as a predictor of pulmonary hypertension, and also if it can be used to calculate the pulmonary artery pressure. So in this study, the diameters of the pulmonary of the main pulmonary artery and multiple branches of the pulmonary artery were measured, and fancy regression analyses were made to figure out what would be the best measure that correlated strongest with the pulmonary artery pressure. So again, in this study, contrast was used. In the earlier study, the study was done without contrast. The CTs were assessed during end inspiration, and using special software to calculate the area of the arteries, they came up with a regression equation that looks like this. It's pretty complicated, but I simplified it here as the main pulmonary artery pressure equals the areas of the right and the main pulmonary arteries divided by body surface area times 0.08 and the total minus 11. So if you take a hypothetical situation of someone who has a main pulmonary artery diameter of 3 centimeters and a right pulmonary artery diameter of 2 centimeters and a body surface area of 2 square meters, you end up with a pulmonary artery pressure of 29 or 30, 29 or 30. So 2 and 3 is too, 3 and 2 are too big for the main and the right areas. And a 2x2 table to look at the sensitivity and specificity of those measures, comparing right heart catheter numbers on the top with the PA diameter cutoff of 28.6, which they considered the mean plus 2 standard deviations. They measured to be 28.6 millimeters, found out that they were accurate 22 out of 27 times, with some false positives, but there were no false negatives. So the specificity was very high, 100%, sensitivity was 70%, and the general accuracy of using 28.6 millimeters to predict pulmonary hypertension had an accuracy of 0.8 or 82%. The equation itself correlated pretty well with the actual measurement of the pulmonary artery. So an R of 0.93, that was pretty significant. The numbers were small, but in the later study, without using contrast, looking only at the diameter, there was a similar conclusion that a main PA diameter of more than 28 or 29 is suggestive of pulmonary hypertension. So the pulmonary artery hypertension is defined as a mean pulmonary artery pressure of more than or equal to 25 millimeters at rest. During exercise, the pulmonary artery pressure increases, mostly because of the increase in cardiac output. The gold standard is still using a right heart catheter to directly measure the pulmonary artery pressure. A pressure of less than 20 or lower millimeters of mercury is considered normal, which leaves a gray zone of 21 to 24 millimeters of mercury, which is still not a defined area. There are a lot of diseases that result in an increase in pulmonary artery pressure. Some of them directly damage the pulmonary arteries. Some of them cause pulmonary vasoconstriction or backup pressure from the heart. The problem here is that the diseases that manifest as increase in pulmonary artery pressure, once they do so, that means they've progressed enough to result in high morbidity and mortality in general. And therefore, cardiac ultrasound, which is a non-invasive way to assess pulmonary artery pressure, is key, because you want to know as soon as somebody has developed pulmonary hypertension to tackle the primary disease that caused the pulmonary hypertension, because if left untreated, morbidity and mortality is very high. So the components of the pulmonary artery pressure, using Ohm's law, where the voltage equals the current times resistance, converting it to fluid dynamics, delta P equals the cardiac output, which is the current, times the PVR, pulmonary vascular resistance, as the resistance. And if you split the delta P into its components, you will end up with the mean pulmonary artery pressure minus the wedge pressure, or the LVEDP, the left ventricular end diastolic pressure, now times the cardiac output, equals the cardiac output times PVR. For diagnostic purposes, it's important to measure the pulmonary artery pressure at rest. Again, I'm mentioning this one more time because a person who is exercising will increase their cardiac output, and if they can't decrease their pulmonary vascular resistance in response to the increase in cardiac output, usually by recruiting reserved vessels that are closed at rest, then the mean pulmonary artery pressure has to increase to accommodate for the resistance and the increased flow through that resistance. So in someone who is exercising and having as they have an increase in cardiac output, and I'm saying this quite a couple of times already. If you imagine someone who has a cardiac output of 5 liters and a mean PA pressure of about 12 or 13, the line of identity here, which is the red line, which is the predicted pulmonary artery pressure increase with increased cardiac output, is not what actually happens. So if you take normal individuals with cardiac output that is at rest 5, and you exercise them until their cardiac output goes to 10, 15, and 20, what happens to them actually stays in the gray area, the shaded area here. They don't follow the predicted line of increase in mean pulmonary artery pressure as a result of exercise. And this says that if you want to measure the pulmonary artery pressure, measure it at rest, not with exercise, but using pulmonary artery pressure measurements with exercise is key for diagnosis and for predicting who needs treatment in response to an increase in pulmonary artery pressure with the exertion. That means they've already maximized the vessels that they can open up to accommodate for the increased resistance. While there are many mortality predictors in pulmonary hypertension, including symptoms, syncope, imaging, hemodynamic measurements, the most sensitive predictors of outcome are the WHO functional status, the 6-minute walk distance, and the BNP level, those 3. So in our patient who we heard about at the start, who presented with dyspnea at rest, unable to walk any distance at her home, and with a BNP of 1500, she's already in the high risk category, predicting a mortality of more than 10%, and this is mortality in 1 year. This is pretty high for someone who might have pulmonary hypertension as a presenting finding of the underlying process. So here you have the WHO, her class functional status is 4. She's dyspnea at rest. She has a 6-minute walk distance of less than 165 meters. She said she can't walk within her house, assuming she has a normal size house. And also her BNP was 1500. Here there are BNP measures of more than 300 being significant, or NT-proBNP, which we don't use in our hospital, of more than 1400 is a predictor of high risk for mortality. Actually, following people out for 5 years, you see here that for someone who is at a high risk, in the high risk group, such as the patient we saw, her risk of mortality or survival is 50% in 3 years. Someone who just showed up to the hospital saying, I've been dyspneic for past 6 months, it's been progressive, and now I'm hypoxic. She is in this area. High risk group would have a 53% survival only at 3 years. So half of those patients die. So it's not a that makes measuring the pulmonary artery pressure to predict pulmonary hypertension very important for survival. So let me put up a question here and see if people in the chat can give me one of the A, B, C, D, E letters as your kind of best guess. And the question says pulmonary hypertension and an enlarged pulmonary artery can cause which of these? Cardiac tamponade by dissection of the pulmonary trunk, hemoptysis by rupture of hypertrophied bronchial arteries, hoarseness by compression of the left recurrent laryngeal nerve, myocardial ischemia by left main coronary artery compression, or all of those. Pulmonary hypertension and enlarged pulmonary artery. Got a couple of E's. I like that. Not a trick question, but these are uncommon manifestations of severe enlargement of the pulmonary artery. So dissection of the trunk can cause tamponade, hemoptysis from ruptured hypertrophied bronchial arteries. You can compress recurrent laryngeal nerve. You can compress the left main. So many things can show up with an enlarged PA. And I thought it's only fair to talk about the WHO classifications of grouping of pulmonary hypertension, so that if I say the numbers, they don't sound so strange. So there are 5 groups. Group 1 are the diseases that damage the pulmonary artery itself or its branches. Group 2 is pulmonary hypertension secondary to left heart disease, where the pulmonary capillary wedge pressure increases. That's why the mean pulmonary artery pressure increases. Group 3 is pulmonary hypertension secondary to lung disease, most common COPD, but there are some places in the world where long-term high altitude exposure causes pulmonary hypertension in the majority of the population. Group 4 is chronic thromboembolic pulmonary hypertension, not only PEs, but also pulmonary angiosarcoma, other intravascular tumors, congenital stenosis, and parasites in some parts of the world can cause CTEPH. Pulmonary hypertension group 4, and multifactorial is the basket where you throw everything else in. Most likely, granulomatous diseases, systemic diseases, renal disease, tumors, other than pulmonary artery tumors can cause this. That's why the pulmonary capillary wedge pressure could be normal or increased. So these are the groupings. 1 is the artery itself, 2 is heart, 3 is lung, 4 is obstruction, and 5 is everything else. Hemolytic anemia has a star because it's sometimes labeled as 1, sometimes labeled as 5. Okay, so in fluid dynamics, the conservation of energy is basis for Bernoulli's equation, Bernoulli's principle. So in a continuum, an area of low flow will have high pressure compared to an area of high flow which has low pressure. So dynamic and static energy have to be constant in total. So measuring the flow difference can give us information about pressure difference. Using point-of-care ultrasound to measure flow, we can estimate pressure. The simplified Bernoulli's equation is here, and it says delta pressure will equal 4 times the flow squared. So how can we do this? We can look at, in trying to predict the pulmonary artery pressure, we have to predict the RV pressure, and in addition to that, we add the RA pressure. The RV pressure during systole, if there is any regurgitant jet from the RV to the RA, that regurgitant jet is going to have a flow in it, and that flow can be interrogated and applied into the equation to come up with the transvalvular gradient. Once you have the transvalvular gradient, you add to this gradient the right atrial pressure, and you end up with the pulmonary artery systolic pressure, what the RV is pushing and what's backing the RV during systole. So you need to have a TR jet, tricuspid valve regurgitant jet, and you put in a continuous wave Doppler line on it, such as here. And you run the continuous wave Doppler, you get a continuous signal that's going below the baseline because the flow is going away from the transducer. The peak velocity is what you're interested in. And that peak velocity here, for example, is 2 meters per second. You square it, it's a 4, you multiply it by 4, that's 16. To the 16, which is the systolic pressure from the right ventricle only, you have to add the right atrial pressure. And you get the right atrial pressure by estimating it from the size of the IVC. You're very comfortable with looking at the IVC to estimate the right atrial pressure. You do this by using M mode or by freezing the picture and scrolling back and forth at a point that's 2 centimeters down from the cavo-atrial junction, and which happens to be immediately distal to the point where the hepatic vein opens into the IVC. Using inspiration and expiration measurements of the IVC and the absolute size of the IVC at rest, which is end exhalation, you can predict the right atrial pressure, and we'll go over those numbers in a little bit. So you get you don't only, it's not only right atrial apical 4-chamber view that can give you regurgitant jet, and I'm getting a glitching picture here, but the idea is to put the interrogation line of the continuous wave Doppler between the anterior tricuspid leaflet and the septal leaflet in the apical 4 view, because in this view you are most parallel to the regurgitant jet of the blood from the RV to the RA. You can also do this with a less commonly used view, which is the RVIT view, the right ventricular inflow tract view. For this view, you start with a regular parasternal long axis with the marker pointing towards the right shoulder, and then you tilt the probe towards the right hip. So you're shooting the beam behind the sternum. In that case, the aorta, the mitral valve, and the descending aorta all disappear, go out of view, and you end up seeing is the RV and the RA and the tricuspid valve. In this case, the posterior leaflet and the anterior leaflet. And this is also a view where you can be pretty parallel to the direction of the jet of regurgitation from the ventricle to the atrium. And of interest, you can see the inferior vena cava coming out of the right atrium in this view also. So this is the RVIT view, a modification of the parasternal long axis view. After you have your jet identified by color Doppler, which will be the easiest way to see it, you put your line of continuous wave Doppler across the valve leaflets into the area of maximum jet velocity, and you run continuous wave Doppler. The signal again is going to be negative, and then you get the peak of the signal to predict the speed of the regurgitant jet. In this case, the speed is 3. You square it, you get a 9 times 4, 36. That's the transvalvular gradient, and you add to that the right atrial pressure. Now, in patients with trivial TR, injecting agitated air saline mixture can augment the image by making the measurement easier to see in theory. So this is an example of a patient who has a pretty faint regurgitant jet, and you can see that with injection of agitated saline, the RV and the RA are filled with bubbles, and now the signal becomes much brighter. However, there is a case series where this was investigated, 29 patients, where 3 to 5 milliliters of agitated saline was injected, and images were obtained on the apical 4 view. The jet area and the length of the jet increased significantly in 20 out of 29 patients, but the TR jet speed measured by continuous wave Doppler did not change significantly. So in theory, you get a much brighter signal. Maybe it makes you more confident of your measurement, but continuous wave Doppler is pretty good in detecting any regurgitant jet. And what your interest is the maximum speed that can be generated. And as far as the IVC, which again you're familiar with the subcostal view, it's best done with M mode so that you can see respiratory phasic change. The only problem is that some folks might be able to generate 100 centimeters negative pressure in their chest when you ask them to do a sniff, therefore collapsing a completely full IVC, while other patients, because of fatigue or poor mental status or abdominal pain, might do only a 5 centimeters negative pressure in their thoracic cavity, therefore not causing a collapse of the IVC when their right atrial pressure is actually on the lower end. So I'll go over the two ways to do this, with a sniff or with tidal respiration, when we go over the table near the end of the talk. But this is the table that's suggested by the American Society of Echocardiography, using an absolute size or diameter of the IVC during end exhalation, so at rest, when you're not exerting any pressure, abdominal or thoracic, and then looking at the percent change with a sniff. And the sniff here is not defined as how strong of a sniff it should be. You get a range of pressures, and the ASE recommend using an absolute 1 number for each of these ranges. So if the IVC diameter is small with high collapsibility, you give the person a 3 centimeters of water pressure. 3 millimeters of mercury pressure for the right atrial pressure. If the IVC is small but it doesn't collapse, you give them an 8. If the IVC is big and it does collapse, they don't give you an actual number to use, but the range should be between 10 and 15 millimeters of mercury. And if the IVC is big and it doesn't collapse, then you give the person a 15 millimeters of mercury right atrial pressure. That's what's recommended. So one more question, and let's see if you can give me a letter in the chat. I have a systolic pulmonary artery pressure at rest as the gold standard in which of these conditions? In long-term prognosis of patients with pulmonary hypertension, therapeutic decision-making for treating pulmonary hypertension, assessment of worsening clinical status, or determining right ventricular failure, the cause of right ventricular failure, or none of the above. I got an A, C, and D. Very good. So the answer I was looking for, so let's see if you agree, is E. The reason I chose this is because long-term prognosis for patients with pulmonary hypertension is really not the PA pressure. The PA pressure will only tell you if the person has pulmonary hypertension or not. What really determines the long-term prognosis are the 3 markers that we mentioned, are the distance walk, the BNP, and the WHO functional class. Using pulmonary hypertension measure with an echo. So that's why I'm saying here systolic pulmonary artery pressure, not the mean pulmonary artery pressure with a right heart cath. This is the pulmonary artery pressure measured by echo. is not that great in therapeutic decision making. For that, you have to do a right heart cath and you have to do a challenge to see if the person is responsive to vasodilators or not, and if the patient's pulmonary artery pressure increases with exercise or not. Assessment of worsening clinical status, because the pulmonary artery pressure estimate using echo is dependent on the function of the RV and also on the right atrial pressure. It might not be the best tool to use. So assessing worsening of clinical status, you have to depend on the clinical parameters and also on doing another right heart cath almost every time there is a change. And also determining right heart failure is a tricky wording here. I couldn't word it any better way. I was looking for comparing a dilated right ventricle versus a thickened or hypertrophied right ventricle. For that, cardiac MR is really the gold standard, not an echo and not measuring the pulmonary artery pressure either. But you can see how all of these there is some utility in using echo in those things, but it doesn't seem to be the gold standard in these situations. All right, so there are some limitations for using echo in measuring the pulmonary artery pressure. The first limitation that I wanted to talk about is that the peak tricuspid regurgitant velocity signal measurement, any error in this measurement is going to be squared and then multiplied by 4. So the standard for ultrasonographers is to be within 20 degrees of the jet flow. And if you look at the cosine of theta, or the graph of cosine theta, for someone who has a tricuspid regurgitant jet velocity of 4 meters per second, if you're exactly in line with the regurgitant jet, so theta is 0, then you're going to measure the transvalvular gradient to be 64 millimeters of mercury. If you are 20 degrees off, then you're going to underestimate the pressure by 7 or 8 points, and it goes steeply down from there as you deviate from being exactly in line with the regurgitant jet. So here's an example of peak velocity, how it changes if you're theta, which is the angle away from being exactly in line with the jet, by 40 degrees. So you have to be just careful. If you're not sure where the regurgitant jet is, you can always underestimate the jet, but you cannot overestimate the jet. So if you get 2 measurements and one is higher than the other, stick with the higher measurement. I said this as a standard rule. Of course, there are case reports of folks measuring the regurgitant jet between the left ventricle and the left atrium by mistake, thinking it's tricuspid regurgitant jet, but it's actually the mitral valve regurgitant jet, and getting very high numbers, and going with those as an estimate of the pulmonary artery pressure when it's actually erroneous measurement because you're looking at a different valve. Second limitation is that the right atrial pressure estimate is usually erroneous. So looking at the IVC has an accuracy rate of only 34% compared to invasive measurements of the right atrial pressure. And this is the number you're going to add to the transvalvular gradient. So there are a couple of schemas and a meta-analysis or a case or a report of multiple schema to measure and predict the right atrial pressure using ultrasound compared 200 patients to an invasive measure for those who were going through right heart cath. And the most two famous ways to do it is Rutschke's and Lang. Lang gives you the range of 5 increments in millimeters of mercury, and Rutschke is what the ASE use as a predictor. The orange circles here are what's considered accurate. On the y-axis is the invasive right atrial measurement, and on the x-axis is the estimate from the echo. And only 34% of the measurements done by echo were in the range that was acceptable, comparing those two invasive right atrial pressure measurements. So there is a problem, and the ASC hasn't come to figure out a way to combat this issue. Multiple other ways of assessing right atrial pressure using the IVC size, diameter, and also pulsatility was used, but none turned out to be better. A third limitation is that in severe TR, you have the echo on average overestimates the transvalvular gradient, pressure gradient, by about 24 millimeters of mercury. So there was a case series of 177 patients with mild, moderate, and severe TR, and they looked at the performance of direct echo echocardiography versus right heart catheter. And this is a Bland and Altman plot where you compare the difference between the two measurements against the average of the two measurements. If the two measurements compared equally or reported equal numbers, all the numbers would be on the 0 line. But it seems here that the average of the difference between the two measurements fell in this area, which had a mean of 24 millimeters of mercury. There are two ideas of why this happens in severe TR. One is that when the regurgitant jet is broad and laminar, the simplified Bernoulli's equation may inaccurately overestimate the TR pressure gradient, because the inertial component of Bernoulli's equation, which is eliminated in the simplified Bernoulli's equation, becomes important and it's not accounted for. The other idea is that with severe TR, you have a highly distended, non-collapsible IVC, so you end up overestimating the right atrial pressure while in reality, when you directly measure the pulmonary artery pressure, you realize that the right atrial pressure is not really contributing to the pulmonary artery pressure in those patients. And another limitation is that if there is no TR jet, you might be tempted to exclude pulmonary hypertension, saying there should be a TR jet if the pressure in the pulmonary artery is high. Well, in a population of scleroderma patients who get routinely screened for pulmonary hypertension, because the incidence of pulmonary hypertension is very high in scleroderma patients, looking at those who had by echo a transvalvular gradient of less than 30 versus those who had more than 30, the negative predictive value was only 50%. Because all of those folks had routine right heart caths. So even if the TR jet is non-existent or very low, in someone who has a very high risk of having pulmonary hypertension, you won't be able to rule out pulmonary hypertension. Now, maybe I've damaged all of your confidence in using echocardiography in measuring the pulmonary artery pressure. I want to say that real-world applicability of using echo for pulmonary artery pressure measurement still holds for the majority of people, majority of the population. So this was a study from France looking at records of 310 patients who had hemodynamic invasive measurement and also an echo done during the same hospitalization. And they compared right heart cath systolic pressure, so systolic pressure to systolic pressure comparison by echo, and the relationship was reasonably tight. You had an R value of 0.8, or with a significant p-value, and also using half of the population as a subset to create the ROC curve. They managed to create an ROC curve with a cutoff value of 38 millimeters of mercury and an area under the ROC curve of a 0.82, which is not bad, meaning that using a cutoff value of 38 millimeters mercury on an echo was reasonable in differentiating those who had pulmonary hypertension and those who didn't have pulmonary hypertension by right heart cath direct measurements. And then they validated this this number of 38 in the second half of the population, and got an accuracy of 86%. So even though there are limitations to using the echo, it does diagnose patients accurately, ruling them in or out of pulmonary hypertension 86% of the time, using a cutoff of 38. And our lab uses a cutoff of 40, which is pretty similar. But my question to myself is 300 patient population study is the only thing that's out there, and it actually is. These are all of the studies that try to validate or compare right heart cath to echo studies in cardiac disease patients. There are only 3 studies, and this report, this meta-analysis, is from 2011, so nothing since then actually. There are only 3 studies with N's that are much lower than 300 in lung disease, mixed causes, and idiopathic pulmonary fibrosis and COPD. Again, these are the studies that were published. The studies that come only close to 300 patients are 2. One here, where 166 patients were enrolled, and here 137 patients were enrolled, with pretty similar or kind of close sensitivities and specificities. So 85% sensitivity and 58, and specificity of 55 and 87 for those 2 studies. In COPD, there were a couple of studies and one in mixed cardiac and lung disease. They all enrolled a small number of patients. For this meta-analysis, hierarchical summary ROC graph was presented, where the size, the study estimate area reflects the size of the study, and you get a hierarchical ROC curve that looks like this, with a cutoff value that gives you a sensitivity and specificity of 0.8 and 0.7. So not too bad for what we have to do. Another question. For a tricuspid valve regurgitant jet of 3.4 meters per second and a CVP of, you measure the CVP and it turns out to be 15 centimeters, what should the systolic PA pressure be? The equation, for those who are tempted to put E, is the transvalvular, the tricuspid valve regurgitant jet squared times 4 plus the CVP will give you the answer. Shouldn't take too long to do if you use your smart device, or if you can square things in your mind. This is a trick question. If you're multiplying 3.4 times 3.4, you will end up with 11.56. You multiply that by 4, you get 46. And the next step is the trick part. Because if you want to add 15 and end up with 61, then you've fallen for the trick, because this measure of CVP is in centimeters, while the tricuspid regurgitant jet predicts the pulmonary artery pressure, the transvalvular gradient in millimeters of mercury. So to convert centimeters to millimeters of mercury, the easiest way to do it is just to take 2/3 of that. So if you take 2/3 of that, you end up with 10, add it to 46 or 47, and you end up with A, with S, with D. Very good. Okay. All right, so what's more important than the actual measurement of the pulmonary artery pressure is to estimate the risk of the patient to in having pulmonary hypertension or not, so that you can decide, does the patient need a right heart cath, to actually measure the numbers. So the ASE has a setup where you can do this reasonably well using the point-of-care ultrasound. You measure the TR jet velocity, and if it's less than 2.8, which gives you a transvalvular gradient of 31, then you look at 2 echo categories, and if you get out of multiple, and I'll go over those in a minute, if you don't get 2, then you have low risk of pulmonary hypertension. If you get 2, then you're in the intermediate category. If the pressure is more than if the flow is more than 3.4 meters per second, this will give you a gradient of 46. You're already in the high category. You don't have to have any other markers from echo. If you're in the gray zone between 2.8 and 3.4, then you again look at other echo markers. If you have 2 or more, you're in the high category. If you don't, you fall into the intermediate, but you don't go into the low category. So high means you're almost definite, and you're going to get a right heart cath. Low, you don't have to do a right heart cath, and intermediate, you have to think about it. So that's the TR velocity. The 2 echo categories are any 2 of these. They look like a lot. We'll go over those one by one right now. So 3 groups: LVRV, the PA itself, pulmonary artery, and then the IVC and the right atrium together. For the LV and RV, what the parameters say is the ratio of the LV to RV, RV to LV more than 1. Is the RV bigger than the LV? Look at the diameter at the valve, and if the diameter you measure at the right ventricle is bigger than the left ventricle, then you get a point. Is there flattening in short axis of the left ventricle? If the left ventricle is flattened, then this thing called the eccentricity index becomes more than 1.1. So D2 over D1 will be high, and that tells you that the ventricle is flattened, as if it's not good enough just to look at it, but you have to get a number. So again, for the basal diameter ratio, you use an apical 4 view, and a ratio of more than 1 gives you RV dilation. For the LV eccentricity index, you do a short axis view, and if D2 over D1 gives you more than 1.1, then it's an abnormal measurement. Next, the PA parameters. You have 3. If the RVOT, Doppler acceleration time, is short, or if there's a notch in mid-systole, then that gives you a point, either or. Or if there's an early diastolic pulmonary regurgitation velocity of more than 2.2. These are a little bit of complicated things that we don't usually do. or the pulmonary artery diameter is more than 2.5 millimeters, which you'd be surprised that with a lot of patients, you can actually get a picture that looks like this, where you are in short axis, you go up to the aorta and tilting up just a little more towards the head of the patient, you see the pulmonary artery in there splitting into two. The same way you see it on a CAT scan. So RVOT acceleration time, you might not do this routinely, but if you do, this distance from the start of the jet across the pulmonary artery valve, the pulmonary valve, into the peak of the jet, if this jet is too fast, that means there's pulmonary hypertension, you get a point. If there's a notch in the jet, that means there's pulmonary hypertension. And if there is a regurgitant jet, a diastolic pulmonary regurgitation that is fast, more than 2.2 milliseconds than meters per second, sorry, that's abnormal. No one is going to do this, but if you're tempted, look at the pulmonary artery, and if the measurement of the diameter of the pulmonary artery is more than 2.5 centimeters, then that's abnormal. And finally, the IVC and RA. If the IVC is big, with low collapsibility, less than 50% with a sniff, or less than 20% with quiet respiration, which I like more than a sniff, then you get a point. Or if the right atrial area is big, which we don't calculate, but if you trace it, the computer, the machine will calculate the area for you. If it's more than 18 square centimeters, then that's a predictor of pulmonary hypertension. Again, IVC diameter more than 21 with low collapsibility, and right atrial area of more than 18 is abnormal. Now, one more question for the brave souls out there. So in group 2, pulmonary hypertension echo, there is usually, or there usually is, which of these? Group 2. So we're talking about pulmonary hypertension secondary to cardiac disease. Right ventricular dysfunction, mid-systolic notch in the PA flow, normal left atrial size, right bowing of the interatrial septum, or a normal left atrial size. Okay, since we're almost done with time, I'll give you the answer. It's rightward bowing of the interatrial septum, because the left atrial pressure in the case of pulmonary hypertension secondary to heart disease, the left atrial pressure is much higher than the right, and it's going to push the atrial septum into the right. So rightward bowing. The others can happen, but they're not usually there. Right ventricular dysfunction is not the main issue. You have left ventricular dysfunction first, and people usually die from that before they die from right ventricular dysfunction. Mid-systolic notch happens in group 1 and 4, more likely than group 2 pulmonary hypertension. Left atrial size is not going to be correct because you have a left atrial enlargement with left ventricular disease. And oh, I repeated the same thing. Okay. So final slide here is if you want to take a picture, this is everything we talked about. This is a description of how to approach pulmonary hypertension patients. You first look at the TR velocity. If it's less than 2.8 and you don't get 2 of these, then you're in the low risk group. If you're more than 3.4, which is probably what you're most interested in, do I have someone with severe pulmonary hypertension that I need to worry about? Because their mortality is high. If you get more than 3.4 meters per second, then you're already there. You don't have to get any extra points by echo. If you have to look for extra points, your most familiar areas are going to be the LV and RV diameters and the IVC and RA measurements more than pulmonary artery measurements. But if you have to do them, you can. The normal limits of descending right pulmonary artery on a chest X-ray is less than 2 centimeters. For the main PA on a CT, less than 3 centimeters. Normal pulmonary artery pressure is mean is less than 20. High is more than 25. Prognosticators are WHO functional status, 6-minute walk, BNP, and this is the table you can use to estimate the right atrial pressure in millimeters of mercury when you're looking at the IVC diameter and change with sniff. Again, you can use change with sniff if you use 50%, or you can do change with tidal respiration of 20%. The equations that I disclaimed at the start is the systolic pulmonary artery pressure using ultrasound is tricuspid regurgitant jet squared times 4 plus right atrial pressure. And this is the equation that reminds me that the cardiac output has a lot to do with what the mean pulmonary artery pressure looks like. So a drop in mean pulmonary artery pressure might not mean improvement in disease, but it might tell me that the cardiac output has come down because of LV failure or something like that. If you have to use an equation, or if you'd like to use an equation to predict the mean pulmonary artery pressure using CAT scan, the equation is one more time here, simplified to 0.08 main and right areas divided by body surface area, and the total minus 11. Okay, so right on time, and thank you for hanging out. Actually, 5 minutes over time. Thanks for hanging out, and check the recordings that Matt Tabbitt puts up on the website. They're great. I sometimes go back and review the lectures that I gave so that I make sure I didn't mess up. All right, I'll hang around for a couple of questions if you have any. Otherwise, thank you.